Greetings everyone, we are from Group 7. We'll discuss retinopathy of prematurity. First of all, my name is Muhammad Hafizuddin Hakimi bin Zulkifli, and our group member consists of Nik Elias Sohana binti Nik Azni, Johan Muhammad Arif Stefano, and Balkis Akilah binti Nur Anas. So, what is retinopathy of prematurity? Retinopathy of prematurity is a retinal vascular disorder affecting premature infants, particularly those born with very low birth weight and before 32 weeks of gestation. It is characterized by abnormal development of blood vessels in the retina, which can lead to scarring, retinal detachment, and, in severe cases, blindness. ROP is a major cause of preventable blindness in children worldwide. Key statistics on ROP are divided into 4 groups. The first one, global prevalence. Approximately 20 to 30% of very low birth weight infants worldwide develop some stage of ROP. Severe ROP requiring treatment occurs in about 6 to 18% of premature infants in developed countries. In developing countries, the incidence of severe ROP is higher, affecting up to 30 to 40% of at-risk infants. Secondly, by statistic by birth weight and gestational age. ROP is most common in infants born at 28 weeks or below, or weight around 1500 grams or below. Nearly 15% of infants born at 26 weeks gestation or below develop ROP, with about 10 to 15% progressing to severe stages. The third statistic, which is impact on childhood blindness. ROP accounts for up to 60% of childhood blindness in middle-income countries. Globally, ROP is estimated to cause permanently vision impairment in approximately 20,000 children annually. Last but not least, the statistic on treatment outcome. Early interventions such as laser therapy or anti-vascular endothelial growth factor injection successfully prevent blindness in over 90% of treated cases. These statistics highlight the varying prevalence of ROP across different regions and populations, emphasizing the importance of tailored screening and intervention strategies to address this condition effectively. ROP is defined by 5 stages. The first and the second stages is a mild cases, which is babies in these stages usually get better without treatment and go on to have healthy vision. Doctors will watch babies carefully to see if the ROP getting worse. For the third stages, which is blood vessel in the reach, some babies who develop stage 3 get better with no treatment and go on to have healthy vision, but others need treatment to stop abnormal blood vessel from damaging the retina and causing retinal detachment. Stages 4, which is of severe cases and indicate there is a partial retinal detachment. This requires surgery and there may be a vision loss even with the surgery. And last but not least, stages 5, which is the very severe cases and indicate a complete retinal detachment. Babies with this stage may have blindness even with the surgery or other treatment. In the next slide, you can see fundus picture for each of these stages.
Next, causes and effects. What causes retinopathy of prematurity? Normally, the blood vessels of the retina start to develop in 4th month of pregnancy and finish developing around 9 months of pregnancy. If a baby is born very early, the disruption to the normal process of blood vessel formation happen and the blood vessels may stop developing normally. The retina then develops new blood vessels that are abnormal. This is called retinal neovascularization. Untreated or severe cases of retinopathy of prematurity can cause abnormal blood vessels grow in the wrong direction. If the abnormal blood vessels grow too far in the wrong direction, they can pull the retina up of the back of the eye and cause retinal detachment. Retinal detachment can cause severe vision loss or blindness. There are some of risk factors that contribute to retinal of prematurity, such as preterm delivery before 31st weeks, which the earlier the delivery, the higher the risk of ROP. Low birth weight, just under 3 pounds or less, respiratory distress syndrome, intracranial hemorrhage, and infections or other medical problems. The progression of the retinal of prematurity. To give a proper management and treatment to the baby's eye. As the condition progresses, signs can be more apparent. The severity of symptoms varies depending on the stages of ROP and whether the retina has become detached. If your baby had ROP that caused damage, you may later notice that their eyes wander, shake, or make other unusual movement, which we call nystagmus. Their eyes also don't follow objects. Pupils look smart, which we call leukocoria, and have trouble recognizing faces.
The examination should be done at the baby around 4 weeks of age and every 2 to 3 weeks until the vascularization reaches periphery or ora serrata, which is its zone 3 area, as you can see in the picture below. The baby criteria is important for indicator risk of baby getting ROP stages become worse and baby should be diagnosed as soon as possible. This is all diagnostic examination list that optometrists do. Firstly is history taking. The second one is visual acuity using a toy, optokinetic drum, or teleacuity. Third one is motility test and pupil reflex. Fourth one is binocular test, which is cover test and Hirschberg. Number 5, refraction using retinoscopy technique such as Mohindra or lens rack. Lastly, and the most important test to do is anterior segment and dilated fundus assessment for allowing better detail of peripheral retina. As you can see below white box, these are the example of fundus assessment such as BIO, OCT, and RedCam. Before doing fundus assessment, it is important for dilating infant eye first. The examination on the baby usually do by the experienced professional optometrist or ophthalmologist, as the technique should be done quickly and accurately. Next, the first picture shows differences between normal baby fundus and ROP fundus from stage 1 until 3 using RedCam, and the second picture below indicator for optometrists to differentiate normal and abnormal eye reflex. Next slide will show how the ophthalmologist doing fundus examination.
On the eye doctor, help. And on the eye, very good. You just take some pictures.
Management and treatment. But first, let's go through for the management of ROP. The management for retinopathy of prematurity involves a combination of prevention, timely screening, and targeted treatments to prevent disease progression and preserve vision. The key aspects of management include screening, monitoring risk factors, and parental counseling. The initial step that needs to do by the examiner is screening. Screening should begin at 4 to 6 weeks after birth or by 31st week of postmenstrual age, whichever is later. Follow-up interval is important depending on the stage and zone of ROP and also can range from weekly to bi-weekly. Secondly, monitoring risk factors also need to be done, such as oxygen therapy must be closely monitored to avoid hyperoxia, as it is a major risk factor for ROP. Also, optimized systemic health such as proper nutrition, infection control, and respiratory support are very important to be monitored carefully, as it can affect the health growth. Lastly, the management for parental counseling is quite important. The aim is to educate parents about the condition, potential treatments, and importance of follow-up so they will be easier to understand. Next, what is the treatments that can be done for retinopathy of prematurity? First and foremost, laser photocoagulation. In severe retinopathy of prematurity, laser photocoagulation is used to ablate the peripheral vascular retina, reduce the incidence of retinal fold and detachment. Retinal vascularization must be monitored at 1 to 2 weeks intervals until the vessel have matured sufficiently. If retinal detachment occurs in infancy, scleral buckling surgery or vitrectomy with lensectomy may be considered, but these procedures are late rescue efforts with low benefit. Patients with residual sclerosis should be followed at least annually for life. Infants with total retinal detachment should be monitored for secondary glaucoma and poor eye growth and referred to intervention program for the visually impaired. Secondly, intravitreal anti-VEGF injections. Intravitreal anti-VEGF injections, or also known as bevacizumab, is an antivascular endothelial growth factor, anti-VEGF, monoclonal antibody that can stop the progression of retinopathy of prematurity. Compared to laser therapy, intravitreal injection of bevacizumab has a lower rate of recurrence and fewer structural abnormalities in select cases. When retinopathy did recur, it recurred months later if a long-term ophthalmology follow-up is required. Concerns regarding systemic absorption and possible infection coupled with the need for optimal dose and timing of follow-up are reasons why this agent has remained a second-line therapy that can be used to treat the severe disease or in conjunction with laser therapy. Moving on to the next, the treatment of eye surgery. In advanced cases, surgical procedures such as scleral buckling or vitrectomy may be required to reattach the retina and restore some level of visual function. Scleral buckling is a surgical technique used to treat retinal detachment caused by ROP, particularly in less severe cases of detachment. The goal is to relieve tension and restore the retina to its proper position, helping to prevent further progression of detachment. However, scleral buckling is less commonly used for ROP compared to vitrectomy because ROP-related detachment often involve more extensive scar tissue, which can complicate the procedure. For vitrectomy, it is a more invasive procedure often used for advanced ROP with significant retinal detachment, especially if there is extensive scar tissue at stage 4 or 5 ROP. The purpose of vitrectomy addresses severe tractional detachment caused by scar tissue pulling the retina out of place. It helps to restore the anatomical position of the retina and may improve or preserve some level of vision. But this procedure carries risks such as infections, bleeding, or further retinal damage. Last but not least, the freezing treatment, which is cryotherapy. Cryotherapy utilizes a probe of freezing the abnormal vessel growth. The probe fills with a gas that circulates to destroy the area of the retina affected by ROP. It then builds a wall stopping further spread of the disease. Only premature babies risk suffering harm from ROP, particularly those born at or before the 30-week gestational period and weighing under 3 pounds. The blood vessel inside these premature babies' eyes continue to grow abnormally within the retina because the wall of the abnormal blood vessels is abnormal. They leak fluid. This reaction, if untreated, can lead to a detached retina in infants and blindness. Once the retina detached, the likelihood of vision is extremely remote. Cryotherapy results in a loss of peripheral vision. However, it prevents blindness that would otherwise occur if doctors fail to act.
To conclude this topic, ROP is multifactorial disease primarily affecting premature infant, characterized by abnormal retinal vascular development, while advancement in neonatal care have improved survival rates. Early detection through regular screening is essential for timely intervention, as severe cases can lead to visual impairment or blindness. Advancement in treatment including laser therapy, anti-VEGF injection, and surgical options have significantly improved outcome. However, ongoing research and tailored approach are necessary to optimize care and mitigate the long-term effect of this condition. And this is our reference. And thank you for watching.